So look, we're constantly told in healthcare that we got to learn from other industries. Look how much safer airlines are than healthcare. Oh, it's like the last mile problem in logistics. But what if some of those companies and some of those comparisons are leading us in the wrong direction? Hi, I'm Bruce Spurlock, a physician and healthcare leader committed to helping professionals and decision makers navigate change with clarity. On Viral Healthcare, we explore the ideas, the innovations that are shaping healthcare, what works, what doesn't, and what it really takes to implement them well. In today's session, we're going to talk a little bit about how much and when and where we should learn from other industries. What does it mean to have cross-industry learning? So that's kind of the topic of today's session. I'm kind of looking forward to this because we've been doing this for years. We've been criticized by a lot of folks. Like, we need to look at technology companies and see how they're doing it. They're very complex. They have a lot of smart people, highly trained environment. They're high paced and we should learn from them. Or the big one, we're just like airplanes. We got to learn from the aviation industry. They dropped their safety record and the safety problems down dramatically, and we should be just like them. Can't we adopt what they're doing? Or how about this idea that comes out of UPS and FedEx and some of the other logistics companies? Maybe we should just think of everything as a last mile problem. Or maybe we should just try to understand how they've been able to handle these surges like they do over the holidays. It's often places where we talk about these things like healthcare is way behind. We're a dinosaur industry. In fact, I just had a friend who's been doing this for a long time a couple of weeks ago saying, I'm really tired of how slow we are to adopt new things. And that's because we compare ourselves with these other industries, which are often go-go industries, cutting edge kinds of places. In reality, the changes in healthcare happen a lot more slowly, but are much more dramatic over time. There is a time when cross-industry learning is important, but it can be also misleading. So what is appealing about learning from other industries? Because after all, if you're a good healthcare leader, you're going to broaden your horizon and think about issues from another perspective. All right. The one idea part of it is that it brings simplification to complex problems. We talked about that last time. It's easy to oversimplify, but what do we like about simplifying? It feels like it's manageable. It feels like it's easier. It feels like we can just transport it directly from that industry to our industry, and it's a proven solution. They've got a track record of evidence, multiple different organizations, time on their side that they've been able to do it. So it creates this kind of sense of urgency. Like, if they can do it, why can't we? So there's this emotional appeal that goes on with a lot of people. Like, we need to modernize. We need to not be, so broken. And there are a lot of modern things out there, but if you've been around a physician's office enough around the country, there are still fax machines out there. I know, hello 1990s. But for most organizations, most practices, most places in healthcare, we're biting off big chunks of adaptation and innovation on a regular basis. So they can seem really compelling to sort of learn from other industries, but I'm not sure they're always right, because they sometimes remove too much complexity. They sometimes sort of suggest all we need to do is just transport and lift and copy and paste their solution into our setting. So what's the problem? Why would we even need to have this conversation? It's that we're misdiagnosing the problem. We talked about this on the last episode. We think we have our good arms around the problem, but we really haven't dug deep into it. We really haven't understand the core issues. And again, I always say root causes. I always put an S on the root cause, because it's almost never one thing. It's almost always a couple or several things simultaneously that we have to think about constantly, simultaneously, and in parallel. So if we think we have the same solution, we'll get the same result. But in reality, we have dramatically different systems with dramatically different constraints. So if you misunderstand the problem, you will misapply the solution. This is, not that difficult, not that rocket science. They sort of taught you this even before I got into medical school about what was the reason you need to diagnose something correctly so that you can apply the correct treatment. Let me give you an example of one of the ways that we're completely different than, say, another industry. So Other industries have issues that they need to scale up and scale down. I think about, again, I mentioned the logistics company at the holidays, Amazon, the same way. They have a lot more movement of product over the holiday period. So they scale up relatively quickly. They hire more staff. They adjust supply chains relatively rapidly. They can increase production to match capacity relatively quickly. It's not so easy in healthcare. Let me, give you just one example. I've talked about a lot, primary care physicians, but if you think about this, nurses are the same way. It takes years of training. So if we flip a switch now and we increase the number of medical schools, or we increase the number of accepted physician candidates that are going to be primary care physicians, it's going to take years for that pipeline to be filled. Then, on top of that, each one of those professionals has to go through some kind of licensing activity. And sometimes that licensing is several steps involved in additional testing and ongoing regulation throughout the time. And then there are constraints. So sometimes we build more primary care physicians, but they go to the inner city instead of the rural parts of the United States where we need them more. So scaling is something that happens relatively slowly. Yeah, we might be able to scale up on the margins a little bit here and there if we have people that are retired or people that are cutting back on their hours. We can scale up and do that. But I think the pandemic was a good example of how our inability to scale up dramatically led to dramatic burnout all across healthcare. So there's something different. This short pipeline versus a very long pipeline like we have in healthcare. It's the same problem. It's a capacity, it's a fluctuation of capacity, but it's totally different realities between the two different types of industries. So I'm not trying to develop excuses for healthcare. I'm just trying to drill down and understand where is it useful and where is it not so useful to do this cross industry learning. So let's talk about some of the structural issues. And I want to dive really deeply. People talk about healthcare as complex. Yes, it's complex. They want to say, yes, it's overregulated compared to other industries, but it is. But really, what are the real problems that are underlying some of these things? They're ultimately operational problems similar to other cross industries, but they usually go much deeper in why they become such structural problems that are resistant and vexing for healthcare leaders to solve. So the first one is that there's really no unified customer throughout the system. So physicians are customers, patients are customers. Patients, when they're not involved with the healthcare system, they're called members. They're customers. Regulators are customers. Accreditors are customers. There are so many customers, and it's not unified. It's not like we're a restaurant or a logistics company where we have to meet the needs of the end user. So the missing unified customer is very dramatic. It means that if we're not all aligned, which is generally how we are, we're going to have different activities pulling and pushing us at different times. So we may think we have a solution and a different customer doesn't like our solution, or it doesn't apply to all of the potential customers. Like, let's say we find a solution in an urban environment, it may not apply in a rural environment, and that's a non-unified customer kind of situation. Another piece that's really unique about healthcare, and I kind of think we like it this way, is that production happens at the point of individual judgment. What does that mean? It means that there's one patient and one or a few clinicians at all. Maybe there's a team of clinicians that are making decisions at the moment. The decisions aren't made high up above, because most of the time, like in making automobiles, for example, we can sort of direct where things happen, but these are individual decisions that often happen in real time in, like, the doctor's office or in the operating room or in the emergency department or somewhere else in healthcare that is not always easy to systematize. It's really hard to make those kinds of things systematic. And we kind of like it that way. We want that physician-patient relationship. We want that I'm a unique human being with my own needs. Even if I have a heart like everybody else, a brain like everybody else, lungs like everybody else, my wishes and hopes and desires are mine. And the relevant changes that are going on with the healthcare system and my own medical issues are different. A third thing that happens in healthcare is that the feedback loop is broken, or more likely really delayed. And you might as well think about it broken if it takes weeks or months or even years from when we make a change for the health status or for the situation to change dramatically enough for us to measure or be able to see. It's often too far away. So we make proximate changes and we have distant or distal effects. And that makes it really difficult because that's not what happens, for example, in a restaurant. You have bad food, your customers don't come back. They know immediately that, you've got a environmental problem because it posts in the front of your window of your restaurant. And then the fourth thing that's kind of important with this is the regulatory frameworks are very, very different. So in aviation, you're kind of rewarded. You're not going to get criticized if you self-refer. But in healthcare, criticism is sort of the nature. People like looking and blaming and talking about where the breakdown is system. The whole malpractice system is set up to be a regulatory framework or judicial framework that punishes problems. More often, you could make a terrible, terrible mistake, but with no bad outcome, you don't have any punishment. But if you have a bad outcome, even if you did everything wrong, you potentially could be punished. It really squelches self-referral. It changes the whole look of I want to self-disclose and be open with my problems. It's very different in healthcare, much more structured and much more layered on it. So if we can't solve structural problems with operational fixes like they do in other industries, copy and paste of those kinds of things is not going to work. So there is some hype, though. I know there's hype. We talk about healthcare should operate just like such and such, or we need to adopt things just like another organization. But again, it oversimplifies the constraints, the time horizons, the reality, the complexity. And really, it just is not the right way to do it. There are warning signs about this. So if a solution assumes immediate scalability, for example, if it assumes that you can flip a switch and make it work right off the bat, or within a very short amount of time, a month or two, that's a real problem. And then ideas that don't account for training or complexity or regulation or some of these other influences are real big warning signs to do that. Now, I've spent most of my time talking about how cross-industry learning doesn't work, but there are some times when it really is helpful. So let's not dismiss it completely because it's important to be balanced about all these things. If the underlying problem is truly similar, or if the constraints are really comparable, it might really actually make a lot of sense to it. If the taking the problem in one area or the solution in one area and adapting it and thinking thoughtfully about what it means to adapt it, not just copy and paste, that actually could work. If there are specific mechanisms that address specific structural features, then we can potentially do this cross-industry learning. Let me give you a couple of examples. So one of the ones that they do in aviation are these checklists. Checklists have had a little bit of a mixed record in healthcare, but let me talk about one that's worked relatively well. It's the surgical safety checklist, and we have a fair amount of research on it, and it's now mandated by many organizations, and most organizations do it relatively well and learn from it. There's still problems with people running through it and thinking of it simply as a check the box phenomenon, but more and more organizations are understanding this is something that is very structurally similar from procedure to procedure in the operating room, that if we just follow these same rules, we'll detect things we might not have found. And the stories of hospitals or surgical teams or other groups that are now running these things, discovering things they might have missed otherwise is really well described. Another one is comes out of sort of the lean Toyota methodology, and that's this notion that hospital flow or clinic open access programs where patients can get in within 24 hours to the doctor they want to see, or where hospital flow is streamlined. Those are often related to industrial engineering topics, and the Toyota processing system, or now lean, has taken some of those ideas and made those much more effective. It's still more complex. It still has misaligned incentives that it has to deal with, but at least there's similar structural components. And so we might be able to adopt pieces of it, or over time get some of those ideas. So the main point to think about with these examples is translate principles, translate mechanisms, don't copy solutions. Copy, paste, is really not effective unless you're, using Word. So, how do leaders need to think about this whole thing with cross-industry learning? What are the most important ways and take-home messages for you right now? So the thing to think about first is this really the same problem? Is it the same as what I'm looking at, or is it similar enough that I can adapt it? What constraints are different? How might it work in some areas but not in other areas? It might work, in fact, in some parts of your organization and not in other parts of your organization that have different forms of constraints, different training, different needs, different capacity. It's just something that you have to think through a lot more thoroughly. What would it require in our system? I like to ask that question, like, what would it take for us to be successful here? And the part I like about that is that if you ask that, not only in your leadership team, the decision-making team, but more broadly, what would it take for us to be successful here? You really start getting ideas from people further down who have sometimes a better understanding of the operational flow. It's that work as described versus work as delivered or done and performed. And they have a better handle sometime if you ask, what would it take in our system to do it? Ask this question: what is structural and what is adaptable? What is something that we really don't have any choice over? So, for example, if we're paying health plan, or we're getting money from health plans or from CMS or from some other organization that's paying us, what can we do in that constraint and what can we not do in those kind of constraints? It's this idea that you can have a filter to think about cross-industry learning. So the way I like to think about it is leaders who import an entire operating philosophy without really understanding the context that made it, theirs and yours, are the ones who generate the most expensive failures. If you don't really understand the context of an operating philosophy that another industry is talking about, maybe even another organization, you're going to have problems. All right, so let's bring it back to where this all comes down to. We really understand our problem. We really have a diagnostic, deep, philosophical, problem-sensing way to think about what's happening. And then we can say, is cross-industry ideas going to add to the risk, or is it going to help us make it a better, more thoughtful kind of way to approach about it? If there's a appeal to the comparison, if there's something that's really emotionally appealing to you, you probably need to spend time, take a step back and think about it more carefully. All right. So now if this discussion resonated with you, I want you to think about a couple of questions and a couple of things you should do that you want to respond to. First of all, if somebody says healthcare should be more like, or healthcare could learn a lot from, I think pause for a moment and ask yourselves, are we solving the same problem or are we just assuming we are? In healthcare, the difference matters more than we think. And I would say it's probably better to be sort of biased against translating something in another industry than sort of being excited about the fact that they've discovered something that we can now use. It doesn't mean it's not useful. It just means that we have to have caution about it. If you like to continue this conversation, I'd love to keep talking to you. You can join me every Tuesday here on LinkedIn, or you can follow Viral Healthcare on your preferred podcast platform. Now, on the next episode, we're going to explore how leaders can make better decisions in a systematic way, and which ideas to adopt and which ideas to leave behind. I'm really excited about that. I'd love to keep talking to you about that. If you have an idea, if you have a trend, if you have an innovation, if you have gone through this decision process and either stopped or adopted, I'd love to hear about it. I'd love to hear your insights. I want to thank you for listening to Viral Healthcare. And if this conversation was helpful to you, share it with a colleague. If they're struggling or if they're navigating change or adopting something that is probably at risk for them to fail, then just share it with them and just bring me some ideas that you have in the future. So until that time, I'm Bruce Spurlock. I'll see you next time.